Yeah, so thank you very much. Thank you for inviting me to this interesting morning. I'm afraid I'm a clinician, so I'm an neonatologist, so I will talk to you about babies. And you might be aware of that we still have a problem with lots of newborn deaths all over the world. So around 2.5 million babies are still dying shortly at birth or shortly after. And we would like to, it's one of the WHO goals to improve the situation. So I was asked to talk to you about a little bit what are the problems. Can you see my slides?
Yes, we can. You might want to put it in presenter mode because at the
last time when I tried that, it goes funny. So it works at.
You can click on the bottom right next to the 75%.
Bottom right. Yeah.
Next to the 75% on the left. There's a little.
Okay. Where does it show? No, that's the start customers to start. Here, there it is.
Yeah.
Okay.
Perfect.
Can you see it now?
Yeah.
Okay, good.
Perfect. Fantastic.
Technique always. Anyway, okay. So I'm talking to you about transition. So what we're worried about once the baby is born, there's quite a lot of changes in the transition of circulation. So as the baby is connected in the womb, the blood flows from the placenta into the baby and back, and the placenta provides the baby with all the oxygen and the nutrition and everything. So there are a massive amount of changes going on once you actually cut and clamp the cord, once the baby is delivered. They're called fetal shunts. So before birth, there's not much blood flowing into the lungs, just about 8% of the circulation to keep the lungs growing, because they don't need to do anything during the pregnancy. And then we have shortcuts in our heart between the right and the left heart. So that's the right heart, that's the left heart. So blood flows directly into the baby's body and into all the organs. So after birth, when we clamp the cord, there are lots of changes going on in the pressures between the big circulation in the body and also the circulation in the lungs. The lung vessels have to open quite a lot. It's called pulmonary vasodilatation. The right ventricle has to start pumping more blood into the lungs to get the blood volume up. And that also requires that the vascular resistance is going down. And for the blood flow to the body, the blood pressure needs to increase. And all these things are very important so that the baby has a stable cardiovascular condition after birth. So in order to improve that, there have been since a couple of decades now, studies considering whether we could improve it by not clamping the cord immediately. So because during the gestation or pregnancy, 50% of baby's blood, it's all baby's blood which runs around here, is in the placenta and only 50% in the baby. The nature is already providing for the baby by shifting more of this blood volume towards the end of the pregnancy into the baby. So it's about 2/3 in the baby and 1/3 in the placenta. And the idea is if you do not rush and clamp and cut the cord immediately, then more blood of baby's own blood can transfer from the placenta into the baby and improve all these circulatory changes, which I've just explained to you. And it would also, if you think about sort of the animal world, that's what animals do. They don't rush and clamp their cord or cut their cord. They're allowed to sort of separate naturally. But of course, there's always a tension, especially if you have babies who are born too early, that people want to start a resuscitation on the baby, might need to help with some breathing and other support. So it was in the 1960s really when we started treating preterm babies, that early cord clamping was performed also for this reason. So I've already explained about the blood transfusion. So what happens if you have more blood from the placenta into the baby, then the baby can also fill up their lungs, especially, which we are very interested in because they start to breathe. And that's how the oxygen goes into the blood after birth. So when we are when we are not clamping the cord immediately, more blood goes into the baby and then more blood can go into the lungs. And if you relate that to an adult, that it's equal to about a 2-liter blood transfusion in the baby if you wait for long enough compared to an adult. It also helps with reducing the fluid shifts and enhancing the stability, because the lungs have to really expand, they have to aerate, and that, as you can imagine, the surface of the lung has then more capillaries which have to relaxed and be filled with the blood for exchange. Another problem which we see a lot in preterm babies is that they need also a stable blood pressure and stabilization, with not a lot of changes in the first couple of the days after birth, in order to be healthy and not getting any of the problems which we see in babies as sort of what we call comorbidities. So one comorbidity is severe intraventricular hemorrhage that's bleeding into the brain in preterm infants, which, as you can imagine, can cause long-term disability. And studies have shown, if you think about the sensor technology, we do frequent blood pressure measurements in these babies. And if you have blood pressures with lots of peaks and troughs, which is represented here by the peaks and troughs of the red lines, that makes the baby more prone to having this intraventricular hemorrhage. So the bleeding into the brain. By babies who are more sort of stable with the adaptation, they have less risk of getting, especially the severe hemorrhages. Lots of randomized controlled studies have been done around the use of delayed cord clamping, or sometimes you can also strip the cord towards the baby if you think you don't have much time. The recommended time is now at least a minute to wait for preterm infants, and that has been shown that if you compare here, this is very immature babies at 22 to 27 weeks, and that the blood pressure in the first 24 hours, and in fact in the first 3 to 5 days, which is what is the transition phase, is much higher and more stable if babies receive the delayed cord clamping compared to immediate cord clamping within about 20 seconds after birth. So there are lots of studies have been done. And another thing, more recently, people have also started considering to actually start the resuscitation for those babies who need it. So resuscitation means, for example, giving them inflation breaths or giving them oxygen whilst they're still connected to the cord. So here's a nice study from the Netherlands, pilot study in babies less than 35 weeks gestation, so not very, very early ones, but the ones which would also normally survive, for example, in ODA countries. And there you can see that they tried to obtain the heart rate in the first few minutes after life. So this after birth, so this is about 10 minutes. And you can see that it takes for the baby some time to reach levels which we normally see in them. So ideally, we want the preterm baby's heart rate between 120 and 160 per minute. So that's much higher than in an adult, for example. And once they're born, there's quite a lot of changes for them, so they need some time to get there. And through this time, as they're reaching their sort of target heart rate again, they're still connected with the placenta. So the placenta provides blood and mom provides oxygen for them whilst they're adapting to the new surroundings, and whilst they're also starting to breathe. So we do have quite a lot of trials showing that there's no need to rush and give them lots of inflation sprays if they start to breathe by themselves. And most of them actually did that within the first 4 to 6 minutes of life. But what this graph also illustrates to you, that it would be very, very important for us to have sensor technology, which gives us a heart rate straight after the baby is born, which we do not currently have. So what we normally use is this demonstrated in this graph here. We have a pulse oximetry, what's called a pulse oximetry, which is a light probe wrapped around the baby's head, hand or feet. And then that gives us oxygen saturation in the blood and also can count the heart rate. However, in the very few minutes after birth, it takes at least 90 seconds to pick up a proper signal. So it will be nice to have some sensors which could do that earlier, so that people can see what is the heart rate of the baby with an objective method, And that would then encourage people actually to do this delayed cord clamping and not to rush and clamp the cord, because if you only listen to the baby's heart, which we of course do, it's sometimes a bit unreliable. It's not very clear, and there can be lots of errors. So it would be nice to have a sort of really reliable method. The other thing, what you can see here with the pulse oximetry, is that it takes a couple of minutes to get into, excuse me, normal, what we call normal levels in us, above 90%. And the reason for that is that intrauterine, the saturation is about 45%. And then once the baby starts breathing and aerate the lungs, then of course they get more oxygen from the breathing air, and then they start and circulate it around their body. So this is one area where sort of non-invasive technology, sensor technology, would be extremely useful, and in fact in all countries, not only in ODA countries, but also there, because we, as you can imagine, the neonatal mortality rate is much higher there than in sort of more westernized or more rich countries. Another problem we are concerned about is in newborn babies, it's about temperature control. So babies, as they are born, inside the womb, they're, nicely around 36 degrees, 37 degrees. Mom keeps them warm, then they come out, especially when they're preterm, and they lose heat quite quickly and can become cold. And then when they're cold, they stop breathing and get lower heart rates again. And when you do this delayed cord clamping, this is a study in newborn lambs, near-term lambs, it shows that the temperature control is much better if they get the delayed cord clamping. And if they get immediate cord clamping, they can drop within the first 10 minutes of life quite quickly. Again, a temperature probe after birth who can control for this, and so that we can take measures like putting them on a certain warm bed and so forth, would be extremely useful. Now, when you summarize all the studies which have been done in preterm infants on what we now call optimal cord management, so delayed cord clamping or milking of the cord, very important. So the major message is, if you do that in preterm infants, wait for at least 1 minute, then that gives you a reduction in hospital deaths by 27 to 30%. So that's quite massive. If you think about, this 1 minute of cord clamping time is, for free. And that is quite impressive reduction in hospital deaths, and that's in all countries, so Western and ODA countries. So a couple of studies have also been done, for example, in India or in Tanzania and South Africa. And there are lots of other benefits, because they get the higher circulatory blood volume through the delayed cord clamping. They need less blood transfusions, which is also very important in ODA countries where you might not have access to red blood cell transfusions. They have better blood pressure. They don't need drugs for the blood pressure. And then if you look at ultrasound and the cardiac output and the function, that's also much improved. There's a reduced risk for other comorbidities of preterm infants, like necrotizing enterocolitis. That's a bad disease of the bowel. They have better oxygenation in the brain, and I've told about the lower frequency of the intracranial hemorrhage already. And we have done some studies on neurodevelopmental outcome at 2 years of age, and there's no adverse effect if you do delayed cord clamping. So it's definitely good for preterm infants, but in order that it will be done everywhere, because people do have barriers and do have worries, can I really wait for such a time? It would be good to have some sensors so that we can monitor the baby and provide care accordingly. Just a short mentioning of term infants. They do benefit a lot as well. The recommended time to wait here is about 3 to 5 minutes now, and that's also adopted by the WHO. And they have similar benefits of delayed cord clamping. So the cardiovascular stabilization is much better. You could measure the temperature of the skin, and you could demonstrate that the temperature control is better. But what is more and most important for them is, because we do not take so much blood out of the baby after birth, and if they get this delay of 3 to 5 minutes, their total body iron at 6 to 12 months is better. And and that is very, very important in ODA countries, because if you have a better iron storage in your body, you have less infections during the first year of life, which is a major cause of morbidity and mortality in babies in ODA countries. So, in deaths in infancy. And the other important thing is, which has been now shown in Sweden and also in studies in Nepal, is that they do have a better neurodevelopmental outcome at 4 years of age. So imagine that you wait for 3 to 5 minutes after birth before clamping the cord, and the babies do better at 4 years of age, and it's for free. So it's quite impressive, I think. Anyway, we have to work on that. So the WHO has adopted that into their guidelines, so recommending doing delayed cord clamping for preterm and term infants, in fact. And that has been put into several action plans. I've shown you here the one from India. They have in India a newborn action plan where delayed cord clamping is part of their pathway of antenatal and perinatal care of the mother and the baby. Of course, there are lots of other things we can improve also in antenatal care, like diagnosing preeclampsia and high blood pressure in the mother, and giving them aspirin if they have this preeclampsia and so forth. So it's nicely part of lots of pathways, and also pathways in the UK now. So we're trying to implement it, but barriers do exist, as other colleagues have already talked about in their talk. So what is the problem if things go wrong? So if you have a circulatory compromise in a baby, there's can be quite a number of reasons. So one we have talked about a lot. So hypovolemia, if the baby hasn't got enough blood volume. If there's peripheral dilatation, which can also happen if the babies, for example, have an infection. And then they're getting sort of into a vicious cycle, so they have reduced cardiac output and venous return. Then the lungs get sick with, for example, pneumonia. They can have toxic metabolites, and you can have things like congenital malformations, which can also increase the risk of all these circulatory compromise. And if you do have that, our outcome measure of survivors or brain damage is much decreased. So another thing I would like you to think about is the condition of the skin. So I've got an interest in microcirculation. So if you think about it, there is some regulation going on, and the skin is our largest organ of the body, if you really think about it. So we have some sympathetic nerves, which normally regulates the muscle tone of the arterioles. So that's the blood, where the blood flows into the body, it's oxygenated blood. Then in the capillary level, it will transmit the oxygen to the tissue and takes the toxic metabolites away and goes back into the vein. And normally we have a sort of stable auto-regulation, what we call a sort of nice balance. And then that's influenced by the nerves. And often we only use about 10% of our microcirculation. However, if you get ill, or if you have changes, for example, in chorioamnionitis, so that means the baby is already infected while they're in the womb, because, for example, the mother has an infection and the ruptured membranes ruptured early, then this steady state cannot work anymore. And you get sort of a swollen part of the capillary bed. And there is lots of water loss losing. You have acute inflammation, so lots of leukocytes walking into the tissue, and you get edema, and that might influence the signals you might want to obtain from the skin. So if, for example, if you have a baby with massive amount of edema, the pulse oximetry, which I showed you on earlier, might not work as well as before, because it cannot pick up the signal that easily. So we have done some work together with the International European Consortium I was chairing to think about, what is circulatory compromise? What kind of would be a definition? So the problem is that there is no international agreed definition. There have been a couple of attempts, and most people would go for looking at the sort of traditional criteria of blood pressure. And for babies who are born too early, we would normally use, we say normal is the mean defined as equal to gestational age, but that's quite an old definition, already 40 years old. We use a measurement which is called capillary filling time and urine output, and for those who can have that requirement for ventilation. So we are now thinking about more, if you have a circular compromise, what is actually happening in the body. So we are mostly worried about this global tissue hypoxia, which I showed earlier in the microcirculation slide, where you have an imbalance between the oxygen delivery and the demand in the tissue, and where the perfusion is impaired. And unfortunately, that's influenced by factors, so like poor myocardial contractility, respiratory failure, if the ductus is still open, if the baby has anemia, infections, or asphyxia at birth, so lack of oxygen at birth. In the moment, the treatment for these conditions are quite sort of traditional, and quite often we do not actually have randomized controlled trials on the drugs which we are using. Another biomarker, so we were thinking about what kind of biomarkers could we use to define this circulatory failure. So one biomarker is called skin-shin gap. So you measure the baby's temperature on the skin and on the shin, and think about if it's above 2 degrees, that means it demonstrates poor macrocirculation, and can be very significant indicator for dehydration or for sepsis, for example. So quite often in preterm infants, this is one of the early signs when they get an infection. So the second one I've mentioned already is the blood pressure. The normal gold standard is to use an invasive arterial catheter if you have a neonatal intensive care unit, but otherwise you are relying on what is called cuff blood pressure measurements. And there it's very important to select the right size and to use a precise application, because otherwise you get wrong results. Again, that has to do with how the sensor picks up the signals. And we have done some work with the International Neonatal Consortium to define for babies, for the young age, that the cuff width should be 50% of the arm circumference, and it should be recorded in which place you're actually taking the blood pressure, and that also has been published now. The other markers which we are using is the heart rate. I've already mentioned that up to 160 beats per minute is normal in a preterm baby, but if that goes above it, that can again be a sign of hypovolemia, because the babies, that's the only way babies can improve their cardiac output, because they cannot, the volume, the stroke volume is small compared to adults, but it's quite a low specificity for cardiovascular compromise. Another clinical sign which is commonly used is called capillary filling time. So what you do, you press your finger on the baby's skin, like here on the foot. So this one is definitely compromised. So normally that should refill within 2 seconds. And together with some other measures like the mean blood pressure, that can be quite a good indicator of circulatory failure.
Sorry, Heike, in the interest of time, because some of our speakers need to leave in 10 minutes, would it be possible to wrap up in the next 2 minutes?
Yeah, okay. Yeah, so we leave the urine output out. And so we have got some other blood pressure, some other criteria. So this is a list of criteria which is currently suggested, which we have talked about. And as this is about sensor technology, what is the clinician's wish list? We would like to have sensors which are skin-friendly, non-invasive, user-friendly, which can be reusable if you are using it, for example, here we have a partner university in Lusaka with whom we are working, and should be also sustainable if possible. So I'm working with Elizabeth Random Morales on such a sensor to acquire heart rate sensoring directly after birth, which should pick up the baby's heart rate rather quickly. And we do hope that in the future we can report on some clinical trials on that. So I would like to thank all the communities I'm working with. I've got quite a lot of networks to work with, and I'm happy to take any questions. So sorry to be overrunning with that. Thank you.